Welcome to the Specialist Unplugged podcast brought to you by the Southwestern Sydney Primary Health Network in collaboration with Highlands Specialist Hub, where we bring expert clinical insights to support healthcare professionals in delivering high-quality care. In today's episode, we're turning our focus to obesity management. We'll be discussing practical, evidence-based approaches to treatment, long-term support, and the role of GPs and specialists in tackling this growing health issue. Leading the conversation is our host, Dr Hanady Nasreddine, and joining her is our guest speaker, Dr Dhanya Sanjeev. I'll now hand it over to both of you to take us into the discussion.
Welcome to the podcast. I'd like to thank the Southwestern Sydney PHN and Naomi Birmingham from Southern Highlands Specialist Hub for organising this podcast. My name is Hanady Nasreddine and I'm a women's health GP, and today I'd like to welcome Dr Dhanya Sanjeev, who is an endocrinologist. Hello, Dhanya.
Hi, Dr Hanady. Thank you for having me.
Dhanya, can you tell us a little bit about yourself, please?
Sure. I'm an endocrinologist primarily based at the Illawarra Shoalhaven region, and I also consult at the Bowral Specialist Hub. I completed my advanced training in endocrinology at the Prince of Wales Hospital, Blacktown Hospital, and Wollongong Hospital. I'm primarily focused on general endocrinology, including women's health issues, diabetes, and obesity management. Thank you.
That's fantastic. So today, I think we're going to be focusing a little bit more about obesity, and it sounds like you have a lot of experience in that area. As an endocrinologist, Dhanya, what is your initial approach to this condition?
Dr. Hanady, thank you so much. Look, I'm very glad that you have chosen obesity as the topic of discussion today. We know it's an established problem, but many a times it is underdiagnosed or unrecognized. And we know 66 to 68% of Australians above 18 years are either overweight or obese. From a specialist perspective, my goal is indeed not to bring my patient's body mass index into the normal range, but instead, my goal is to provide them with the maximal health benefits that I can through facilitating weight reduction. Studies have shown that even 5% of weight loss can provide health benefits, such as improving blood pressure, improving glycemic control, or reduction in overall cardiovascular events, or it could be improvement in obstructive sleep apnea or other metabolic parameters. So my aim is to deviate them towards a healthy weight goal. In addition, as an endocrinologist, I would be definitely focusing on ruling out endocrine conditions that might contribute to weight gain. Just as an example, I'm saying I had a patient who was 35 years of age. She was referred to me to optimize her glycemic control prior to bariatric surgery. Interestingly, on clinical examination, she had very overt features of Cushing's syndrome, and subsequent investigations proved that she has an ACTH, which was contributing to her weight gain. So this patient, instead of having a bariatric surgery, she underwent a pituitary surgery, and she lost about 80 kilograms of weight over 2 years after the surgery. So it's very important to recognize endocrine conditions. They're not that common, but of course we can see such conditions. And a couple of days ago, I saw a gentleman who had bariatric surgery in September. He saw a neurosurgeon recently for back pain, and the neurosurgeon suspected he could have some acromegalic features, and he referred him to me. And this gentleman has very overt features very clear features of acromegaly. So it's quite crucial to rule out endocrine conditions in patients facing obesity.
Okay, that is very important. And are there any other considerations that GPs should have when addressing or first identifying this issue with patients?
My advice to GPs or any physicians is that obesity is one of the most complex medical conditions, and a general practitioner alone or patient alone or a physician alone cannot fix that problem. So it is very important to involve multiple teams such as dietitian, assess their psychosocial factors, and involve a psychologist if needed, especially if the target weight reduction is quite high. Secondly, I would recommend not making any assumptions in patients who are obese. Unfortunately, stigma is quite common, and our attitude can affect the outcome of their weight loss. We should never give the impression to patients that this is because of their sedentary lifestyle, because they are not putting much effort, or due to a lack of motivation. We should never give that kind of an impression to patients. Another thing I would like to say is always look for or assess for comorbidities and see whether they have any unusual features to suggest an endocrine condition.
And when first seeing a patient, what would you advise the management plan should look like?
From my perspective, patients who are obese, they need quite a long history taking. We need to assess their mood, their occupational factors, their psychological factors, other social factors. So history taking is very important in this condition. And as I said, assessing for comorbidities and ruling out other endocrine problems or contributing factors are very important. After doing this, my first step would be to assess the patient's medication history. Some patients could be on certain medications that can promote weight gain or could be an obstacle for losing weight. Just as an example, a diabetic patient on sulfonylurea or on high dose insulin, this can be addressed by the physician. Or there might be patients who are on psychotropic agents that could promote weight gain. In such situations, of course, in liaison with the physician who comments those medication, I would consider modifying that regime. That's the first step. Secondly, I would discuss with the patient about the weight goal, and this would be a discussion. I often set the goals based on the patient's preference. Generally, I don't set the goal myself. I wouldn't tell my patients to bring your weight down to 60 or 65 kilogram. Generally, I advise for probably a 5% weight reduction to begin with, but many patients would tell me at that point, well, I would prefer to have a bit more of weight reduction. Some patients it could be 5 to 10%, and some patients it could be even up to 30%, in which case we need to discuss about bariatric surgery and all. Next step would be to discuss about the various pharmacotherapy options to patients. And as you know, GLP-1 agonists have become the standard of care these days.
Yes, GLP-1 agonists have definitely entered the obesity management landscape. Could you tell us a little bit more about the GLP-1 agonists and their metabolic effects?
GLP-1 agonists, as you know, they are incretin-based therapies. Primarily, they reduce the gastric emptying. They also have effects on the satiety center, and they have got multiple metabolic effects. Metabolic effects include improvement in glycemic control, improvement in blood pressure, and you might also know it reduces the apnea-hypopnea index significantly, and these medications are currently recommended as a treatment for obstructive sleep apnea as well. They reduces steatosis of the liver, and they have got proven cardiovascular benefits and renal benefits as well.
The gastrointestinal side effects are common. Could you specify the adverse effects for us regarding these GLP-1 agonists and those that are commonly reported or most commonly reported by patients?
Sure. The commonly reported side effects that I see include gastrointestinal side effects, of course. Due to the reduction in gastric emptying time, many patients report a feeling of bloating or fullness, which might be uncomfortable for some patients. This could be in the form of worsening of gastroesophageal reflux, and in some patients, nausea, and in extreme cases, vomiting. Vomiting is very rare. I haven't seen many patients reporting vomiting. Constipation is quite common. I feel this could be because of the reduction in appetite. Many patients forget to drink enough water. Diarrhea is also common in certain category of patients. And some rare side effects include I had a few patients reporting headache, especially 2 to 3 days after having the dose of the medication. And some patients have reported sleepiness or drowsiness. I'm not sure whether this is kind of normalization of their sleep pattern cycle, because many patients who are obese reports a disrupted sleeping pattern. I'm not sure whether it is that they are turning towards a normal sleep pattern. This happens. These are the common side effects that my patients report. Of course, there are certain concerns about risk of blindness and macular degeneration, especially in patients who are above 60 years of age. But we need more studies. And of course, many of the side effects won't be evident until these medications are in clinical use for a substantial period of time. So, time has to prove. And yeah, recently there was another concern about this medication affecting or causing erectile dysfunction. Again, more studies and trials are needed for this.
Thank you for that, Dr. Sanjeev. What are your preferences when it comes to the use of GLP-1 agonists? There are a few available at the moment, but what do you tend to use and prefer in your practice?
We have got liraglutide in the market. We have semaglutide in the market, and we got tirzepatide, which is the dual agonist. The choice is, it ultimately depends on the patient profile. As an example, if I have a patient with diabetes with HbA1c above 7.1, I would choose the semaglutide for that patient, given they could get PBS subsidy for that medication. Of course, if I have a patient who has a really high target of weight loss reduction, like about 20 or 25%, I would go for the tirzepatide, the dual agonist, which has got superior weight loss benefits. And availability is also another issue. If there's a shortage of one of the medication, then I might have to switch to another one that is available as well. So it's all based on the patient profile, how much they can afford. Yeah, there are these factors. That's what I consider before choosing the medication.
Okay. And you did mention cost. The GLP-1 agonists are quite expensive. Patients who have achieved their target goal and they have achieved the benefits of their weight reduction, what are the long-term, how long do we anticipate patients being on these GLP-1 agonists? And if they are keen to wean off, what is the weaning regime, or how do you wean these GLP-1 agonists?
Yeah, that's a great question. To be honest, there are no clear set guidelines on how to wean off these medications. One thing is, obesity being a chronic disease, long-term treatment is required for efficacy. There might be patients who would wish to continue or remain on the treatment because they are tolerating the medications very well. My approach is, once my patients reach their target achieved and it is sustained for 6 months or even up to 12 months, I would discuss on weaning the dose of the medication. Very important is we should emphasize the importance of lifestyle changes upfront. Even when we start patients on this medication, at every visit, we should remind them of the importance of lifestyle measures for the success long term. So if I am supposed to wean the patient off the medication, of course, the patients lose the benefits that they are having from these medications, and they're very likely to regain their weight. So lifestyle measures and exercise is very important, especially when we are planning to wean off the medication. We can think of other pharmacotherapy agents, introducing other agents as well, but the problem is the weight loss benefit is not as great as these medications. So it's a bit challenging, and of course guidelines need to be established.
Dr. Sanjeev, some of the surgical options do, and the surgeons do recommend the use of GLP-1 agonists before surgery. Could you tell us a little bit more about these options, particularly surgical options?
Yeah, sure. Of course, bariatric surgery is a consideration in patients whose target weight reduction is above 30%. GLP-1 agonists the tirzepatide particularly, we can achieve a weight loss benefit close to bariatric surgery up to 25%. But if the target is beyond that, of course, we may have to think of bariatric surgery. GLP-1 agonists are used prior to bariatric surgery to promote weight loss. But I feel a month before the surgery, that's what the guidelines said, the anesthesia guidelines. They recommend ceasing the medications a month before the surgery in view of the effects on the gastric emptying and the associated risk during the anesthetic procedures. Generally, I advise my patients to consider a very low energy diet prior to bariatric surgery, just to enhance the weight loss prior to surgery. And of course, these medications can be considered after the surgery as well. But I should say I had a patient who was on GLP-1 agonist after gastric bypass surgery, but she ended up having an anastomotic leak, a perforation, due to the acidity related to the reduced gastric emptying from this medication. So it's a little bit tricky. They need to be constantly watched and monitored if they are on ongoing GLP-1 agonist treatment after bariatric surgery. And the other factor to consider is to replenish their nutrition. Many patients, since their appetite is shut down, they may get nutritional deficiencies. This is on top of the nutritional deficiencies related to the bariatric surgery. So it's always important to watch for that and remind patients of having nutritional supplements as well, particularly protein intake, micronutrients, and vitamins. Thank you.
Thank you so much, Dr. Sanjeev, for sharing your expertise with us today in the area of obesity. Your specialist perspective has been invaluable. It is definitely a common condition that we manage and see in general practice today, and I'm sure our listeners have benefited from your expertise.
Thank you so much for having me. I hope you have a great day.
Thank you.